Helen Buckingham. I'm the Director of Strategy and Operations of the Nuffield Trust, and I've been part of the steering group that's organised these sessions alongside Helen and Rakir from HSI UK. And I'm really delighted to welcome everybody who's here today. We've got quite a large number of researchers in our audience, which is fantastic. We've also got people with lived experience, people who are the people that we absolutely want to be working hand in hand with as we think about how we develop our more inclusive approach to research. These events have been quite a long time in the making. We've been talking about them for a number of months because it's a really important thing for us to focus on, a really important topic. Research is not an end in itself. We don't just do research in order to be able to talk to other people in ivory towers. We undertake research because we actually want to make a difference. We want, in this context, to make the health and care system better. And how can we do that if we don't have the perspectives, the experience, the sight of people who actually use health and care services and people who deliver health and care services in our minds, working with us as we undertake the research, right from the beginning about thinking about what questions we want to research, through to thinking about how we put our findings out there and actually make a difference as a result of the work that we do.
I'm Dr. Lillian Hunt. I'm from Wellcome Trust, but primarily my role is to run EDIS, which is the Coalition of Equality, Diversity and Inclusion in Science and Health. I think Helen really hit the nail on the head there with we don't do research to just talk about it amongst ourselves. We're trying to do this for real public benefit, patient benefit, and really to make a difference. I think it's quite easy to sort of forget that that's the actual intention rather than publication. It's to make a difference to people and to really make sure that people are engaged with and involved in it, so that they also, everyone has a responsibility as to making the research system better and taking on a little bit of that input to really improve what it is that we come out with at the end. EDIS as a coalition is taking that systems level approach. We're thinking about all the different sort of aspects of research, all the different sort of players in the system, and understanding actually where does each one have a different sort of lever to pull for equality, diversity and inclusion within the science and health and research sphere. Some of these are our members, and some of them are funders, some of them are research institutes, some of them are from industry. Some of them work at different specific stages of the research cycle, and others have ownership of sort of how that's communicated and embedded within our lives and society, but charities in here as well. And I think this is really important. When we're talking about systems level, I saw that there was some sort of interesting why we're here's there, and some of it was about like what can we do as an organisation? What can we do at the organisational or institutional level? And that's super important, but it's even more important to consider that in the wider context of what everyone's doing in this space as well. So I think that's kind of our approach to doing things, and hopefully I'll be able to explain a little bit why. But generally what we find is, if we're all working towards some sort of collective or collaborative goal, each organisation will have a different part to play in that, and actually pulling all those levers at roughly the same time creates this real tidal wave of change. I think it's really important to emphasise that collaboration, that cross-sector collaboration especially, is the thing that's going to really push some of this work forward. We can take fantastic examples from individuals and from individual organisations, and you'll hear more of them later today.
One of my first passion is around doing social research, leading to social justice. And my second passion as a sociologist is systems and processes. And so I've always treated systems and processes not as a given, really, but they're malleable. We're able to change and transform and bend to our needs. And that is really where all my work has been steeped. And so my portfolio of work really is about patients and public's involvement in research to develop an empirical voice in order to change and transform policy, research and practice. So regardless of the name you want to kind of package them in, that they've effectively then gone on to actually change and improve services, what is relevant to them as well as to other young people. However, it's a given that young people and the community will receive training in order to fulfil this role. The biggest challenge, what I want to focus on, is the role of the system. in actually accommodating young people to actually marshal evidence to create this type of change. And I wanted to share with you in this small section some of the kind of key learning and reflections I've come across in my time to actually look at the solutions to actually overcome some of these potential problems. So the first one, or the first challenge really, is how you leverage in young people and community members into organisations to actually undertake research. The quick win and the easiest win for me has always been going to their corporate strategy. And so identifying in their corporate strategy or their overarching plan, how do they perceive and what indicators or metrics do they attach to public engagement? And so linking your project or your activity to the overarching strategy of the organisation is a nice way to leverage in the involvement of the community and young people as researchers. In terms of training, so like I mentioned, normally it's a prerequisite really that we do train and support community members doing research. But what I've always emphasised and done in my work is to ensure that training for people in the systems, the agents within the system, is always taking place. And these may be individuals directly or indirectly involved in the project or the study being undertaken by the community doing research in that organisation.
So I'm here to talk a little bit about how we can encourage more inclusive research culture, as the rest of us are. For me, this is it really sums up with the challenge we're facing, I guess. So co-production or faux production is the question. And the quote says, "Oh yes, we co-produced our project. We sent a survey out asking what those people thought of the final report." Big sigh. For me, that really sums up a lot of the challenge. There's a lot of misunderstanding around what co-production is, but I'm here to talk about co-production, but it's bigger than that. There's a lack of an understanding around kind of what we mean by inclusive research and the change that the system is looking to make, what that is and how we go about doing it. And I suppose we don't have a definition of co-production, but what we talk about is our approach. And it's a co-produced approach, working together in equal partnership for equal benefits. And I'm not saying that co-production is for every piece of research, but I really think the principles and the core values that underpin it, they are really important for all research, for inclusive research. And they can and should be used across the research system in order to assist in making this a better and more inclusive culture. So all of this work is very much underpinned by our core values. And they're really important to us because they're what takes our work from a way of doing and a methodology to actually a way of being, a way of living and breathing this inclusivity that we're aiming to achieve. And it's an approach any organisation or individuals can follow. We co-produce these values, but what is really important is that we live and breathe those, that we truly sign up to them, because without that, it's just some words on a piece of paper.
I'm Shahid Mohammed, and today I'm going to talk to you on behalf of the Renal Patient Support Group around online educational consultations surrounding chronic kidney disease, providing perspectives on the pediatric and adult side of chronic kidney disease. And it's been an honor and privilege to be presenting in this forum. So I'm just going to run through this presentation, focusing on four main points, and that is patient-centered educational online consultations, interprofessional collaborations for health practice and excellence, educational topics and tags, and the Renal Patient Support Group sort of overall experience. Next slide, please. So a bit of I guess background around patient-centered online educational consultation. So the UK government a while ago sort of emphasised the importance of improving health outcomes and providing smarter patient-centric care. And initiatives that relate to that would be supplementary or additional to the care that patients with, for example, chronic kidney disease. Those going through nephrology service sort of already encounter and link with their electronic patient records. Online consultations across several educational themes or topics and sort of doing some baseline sort of research around this would actually help to reduce inequity, increase literacy, health literacy specifically, language, and improve overall healthcare for those facing chronic kidney disease. And one way to achieve that has been to additionally would be to sort of integrate an instant messaging forum that can sort of space with those support groups to integrate patient records. When I mentioned we did a brief sort of kind of investigation around this, we looked at educational topics and topic tags, and that'll be in another slide. But the threads generally that are generated through social media platforms and online support groups, for example, can help identify clinically and non-clinically relevant context. And we did publish a paper around that just about a year ago. And the data that's come out of that initial sort of pilot data, really more than anything, has highlighted that delivering educational support through online podcasts and webinars, or and sort of highlighting that efforts over a decade since the conception of for example, the renal patient support group has been been out in the public domain. Is also where the NHS and aspects of healthcare sort of still require reimagination. And the RPSG has been the first international sort of retrospective online space that examines this sort of educational perspective between online pediatric and adult sort of renal cohorts and in close to 2 decades. And what we also found that in the work that was done is that co-developing educational modules involving patients and professionals would prompt more joined up care and thinking in meeting and addressing healthcare inefficiencies.
So I'm going to talk to you about a piece of work that I've done with my colleagues at the Nuffield Trust, Jonathan Spencer and Avina Raleigh. We did this work really to understand more about the quality of ethnicity coding in health service data sets. So data sets that we use at the Nuffield Trust day in, day out, and that many other researchers use as well. So why did we want to do this? Why does it matter? Well, understanding ethnic differences in health requires us to be collecting data about ethnicity alongside the information about health conditions and experiences. And if we don't have that data, then we can't really understand if there are differences between different ethnic groups in access or quality of care or outcomes. And one of the things that's really come to the fore, I think, with trying to understand what's been going on with COVID is that actually many health-related data sets don't routinely include ethnicity. So, for example, information about COVID testing, that data doesn't have ethnicity in it. So what tends to happen is that the data in existing health data sets is used to attribute the ethnicity of somebody. So by linking 2 data sets together in order to add the ethnicity to, for example, COVID testing or infection data. And that means that as well as any issues with the data quality in the hospital data affecting the any analysis of hospital data, it also is affecting analysis much more broadly. And so this has been a concern prior to COVID, but I think there's been more focus on it as a result. In terms of our key findings, one of the things that we found is that there's an excessive and growing proportion of patients that have a category recorded of not known, not stated or other. That there's incomplete coding and inconsistent use of codes. So some people having multiple codes on different times they use health services. That there are systematic biases in data quality. So, for example, it's worse for planned operations than for emergency care. It's worse in London than in other parts of the country. It varies with deprivation and between age groups. And that also the coding problems disproportionately impact on minority ethnic groups. So in particular, the coding is a lot less consistent in minority ethnic groups. So that's a particular way in which bias might get into our analysis of this data. And then in our report, we also look at recommendations for improving coding. And there's action we think needed by national stakeholders, by NHS organisations, and engaging with patients and staff to really improve the dialogue about ethnicity data and how that's collected.